Okay.
Bismillahirrahmanirrahim.
Kuat.
Kuat lagi. Dengar ni.
Dengar lebih kuat dengar.
Bismillahirrahmanirrahim. Assalamualaikum and a very good evening to all of you. Today I will teach about acute kidney injury. Some of problems for our kidney. Okay. Before we go to our teaching outline, can someone of you tell me, is kidney vital in our body function or not?
Yes.
Okay. Then we go through the video.
Okay, can.
Video. Okay. Video. This video will show you the importance of kidney, the vital of kidney in our body, and where is the kidney is located, and which part in our body is called kidney.
Hi kids, you all know that some organs in the human body are necessary for survival. You necessarily
So this is the cartoon of the kidney that can talking like us.
Oh,
Okay.
wait a moment. You must be one
It
of
show our kidney vital like our heart, lung.
Yeah, I am kidney. I am very important for your body. You need at
She is
least one
kidney.
kidney to stay
At least
alive.
one kidney is needed to stay alive.
Do you remember
One kidney is
what
enough to filter our blood.
a kidney looks very similar to kidney beans.
Kidney shape like kidney bean,
Each kidney is about 8
8
centimeters
cm to or 3 inch, the size of our
and
kidney.
about 13 centimeters, 5 inches long. Do you know? Kidneys have a lot of work to do, and that's why we
The kidney have a lot of works to do.
One of the main jobs of the kidney is to filter the waste.
Filter the waste out of the blood.
Now look closely. Kidneys filter your blood and make urine. Blood passes into the kidney via renal artery. Anything
Look at the
from
posterior of
the
our
kidney is called
body.
and it returns through the renal vein. Once inside each kidney, the blood vessels enter capillaries and then enter thousands of tiny structures known as bone
Okay, in our kidney,
Now,
that she talk have tiny culture,
blood is under
what we call that nephron or glomerulus that filter the waste out.
Pass out the capillaries and enter into the kidney tube that is called the nephron. Now, the lipid is
Nephrons.
processed. The coil part of a nephron makes sure that glucose doesn't escape into the urine. The loop of Henle makes the urine concentrated, so that water is conserved. There are thousands of nephrons, and each of them makes urine. The lipid
Okay, there was 1,000 of nephrons in our kidney, not only 1 or 2 nephrons, 1,000 of nephrons.
When the bladder is about halfway full, your body tells you to go to the bathroom. When you eat, the urine
Okay, after the kidney
goes
filter the blood,
called
the excreted waste will store in the bladder, and the body
Now,
tell
you
us
know
to
how kidneys filter
waste out the wasting
Now
out
look
of
at
our
this
body.
urinary system diagram. The kidneys, the
The
bladder,
first kidney,
and their tubes are
ureter, bladder, and then urethra.
here. You can
Formation of urinary
all of
system.
the parts of the urinary system. The kidneys, filters that take the waste out of the blood and make urine. The ureters, tubes
The ureters carry urine from kidney to the bladder,
the bladder.
and bladder the storage for the urine.
The urethra, a tube that
Urethra carries out the urine from our body.
Now, some other tasks performed by your kidneys. They balance the volume of fluid in the body.
Function of kidney also balance the volume of fluid in our body.
If the volume of fluid in your body goes down, the kidneys will
Prevent
not
our
flush
body
urine
from
until the amount
urinate
of fluid in
or
your body
toxic.
goes up. They help in making red blood cells. The kidneys make a hormone that
function in
tells the
making
body
red blood
when to
cells,
make some more red blood cells. Kidneys can change blood pressure. The kidneys
change
make
blood
hormones that
pressure,
can constrict the
maintain
arteries
the
in the
normal
body.
blood pressure.
This causes blood pressure to rise when a higher pressure is needed to make sure that blood gets to all parts of your body. They produce active vitamin D.
Okay,
Vitamin D
kidney
helps
also
the
produce
body
vitamin D,
absorb
yeah.
calcium from dairy products and some other foods that you eat. Calcium is needed to make strong bones and teeth. Now, you know we perform so many tests, and we are very important for your body. So, you should take proper care of us.
Okay, you should take proper
Don't
care
get
of our
afraid.
kidney.
It's very simple and easy to take care of kidneys. You don't need to follow any tough procedure. Drink plenty of liquid, like water.
Okay, make sure drink plenty of water,
Always eat a healthy diet.
have healthy
Do
diet,
not consume alcohol and say no
do
to
not smoking and
never
alcohol.
take drugs. Isn't it
Take
easy
care
to
of our
take care of your
kidney.
kidneys? Oh, did you notice how nicely you have understood all about your kidneys? Now, share this cool video with your friends. Stay tuned for more science videos.
Okay, she asked you, have you understand what the function of kidney?
Yes.
Okay.
Understand?
Okay, next. Our content outline for our title today, anatomy of our kidney, definition of acute kidney injury, pathophysiology of acute kidney injury, clinical manifestation of acute kidney injury. Next, management of acute kidney injury, like always, and nursing care of client with acute kidney injury. Okay, next, there is anatomy of our kidney, external view and internal view. We have here renal artery, renal vein. Renal artery, the blood comes from the renal artery and filter here in the interlobular blood vessels. All the nephrons, all the loop of Henle, what we call that, tubular, all the tubular located here, filter the blood here and excrete out through the renal vein. Okay, next. Renal failure or kidney failure is a situation, sum of situation in which the kidney fails to function. And fail to function means that the kidney fail to function adequately, like normal, and decrease in our GFR. Okay, there was two forms of acute renal failure. First, acute kidney injury, and then chronic renal failure. Okay, type of renal failure was determined by drop in glomerular filtration rate and increase of serum creatinine. Okay, like we go to chronic renal failure. Chronic renal failure, the sign of chronic renal failure, we can observe from a patient that have anemia and small kidney size. Okay, next. There was video for acute renal failure, some simple video to make you understand more about acute renal failure. Okay, what you need to know.
What do you do when serum creatinine value from a patient you see in the ER is elevated?
Okay, patient that suddenly have increased creatinine value, there was a sign and symptom of acute renal failure. Okay, increased creatinine, decreased GFR. Okay, also urine output decreased for 1500 ml per day.
Decide if the low GFR is acute or chronic. If no
We
previous
can differentiate
available
patient have an
suggestions
acute kidney injury or chronic kidney injury.
strongly suggestive of chronic kidney disease.
Chronic kidney injury, patient will have smaller kidney than acute kidney injury.
Next,
Okay,
this
next.
is ARF. Is it 1, pre-renal, decreased renal blood flow, but no
causes of acute renal injury. First, we have pre-renal that come from blood vessels or some outside causes. Renal, intrarenal from the kidney itself, and post-renal from the bladder.
One, pre-renal, or ARF. Check
Okay, for
fractional
pre-renal,
excretion of sodium.
we should check the blood investigation for the sodium
Sodium less than 1% is predictive of pre-renal failure.
less than 1%.
Fractional excretion of sodium more than 2% is predictive of ATN. Note there are many exceptions.
Pre-renal can cause by acute renal necrosis
For
or pre-renal failure, and then intrarenal we can check from investigation like urine analysis.
Use the urinalysis to help diagnose AIDS. 3. Post-renal. Finding a bilateral
Okay,
hydronephrosis.
post-renal, the sign is bilateral hydronephrosis that can be observed from ultrasound guided kidney user bladder. Okay, for management, pre-renal,
2. Renal. Treatment for ATN is supported. Avoid
supportive care for intrarenal,
treatment of
no
RPGN.
nephrotoxins.
AIN depends on the results of the workup. 3. Post-renal. Removing the obstruction will improve
Post-renal, we remove the obstruction like kidney
and
stones.
the duration and severity of the obstruction. If the cause of ARF cannot be easily treated, manage its consequences.
Okay, cause not easily treated, like the video shows. If the cause not treated, we should have patient for urgent dialysis because patient will have acidosis, electrolytes imbalance, and intoxicants in their body, and volume overload. And also patient will have severe uremic
For example, pulmonary edema.
that can cause centrally nervous system affected.
In summary, when your patient's serum creatinine is elevated and represents
For
acute
increase of
failure,
serum creatinine,
following this approach
we
will
call
take
acute renal
from
failure.
diagnosis to appropriate management.
Okay, next. Okay, we go through acute kidney injury. The definitions previously called acute renal failure, rapidly decline, suddenly decline in renal function with azotemia, fluid and electrolyte imbalance. Generally characterized by oliguria. Next, major trauma surgery, where the kidneys are deprived of normal blood flow for an extended period of time. Heart bypass surgery, for the kidney receive reduced blood flow, hemorrhage, massive blood loss, infection, drug and radiologic contrast media. Okay, there was the risk factors of AKI. Okay, for pathophysiology, we divided for 3 here: pre-renal, intrinsic, and post-renal. Okay, next. Okay, causes of pre-renal acute kidney injury. Like we go through the risk factors of acute kidney injury. There was volume depletion that caused by vomiting, diarrhea, burns, and inappropriate diuresis. Next, renal artery stenosis or hypotension, cardiogenic shock sepsis, medications like NSAIDs and ACE inhibitor, and radiological contrast agent that we use for radiological procedures. Okay, there's we show pathophysiology of pre-renal AKI. Failure caused by a true hypovolemic or reduce of effective circulating volume. Next, a drop in renal blood flow causes our GFR to fall. And next, filtration of substances by the glomeruli is reduced, and less reabsorption of kidney from the less reabsorption of substances from the kidney in the tubule is required, and then kidney cells require less energy and oxygen and slow metabolism. Okay. Little physiology, prerenal, ineffective function of the kidney, less function of the kidney. If continuously ischemic, can lead to tubular cell necrosis, or we call that acute tubular necrosis, and significant nephron damage. When if rapidly reversed, when blood flow is restored back, the renal parenchyma remains undamaged. Okay, causes, intrinsic causes of glomerular disease like SLE, systemic lupus erythematosus, acute glomerulonephritis, interstitial nephritis like drug-induced NSAIDs, SLE, drugs, infections, pyelonephritis, tubular injury, hemorrhage, drug overdose, hypercalcemic, and for vascular like vasculitis, hypertensive crisis, renal artery, or vein thrombosis. Okay, intrinsic AKI characterized by acute damage to renal parenchyma and nephron. The most common cause acute tubular necrosis induced by ischemic and occurs when the reduction in renal blood flow leads to necrosis. The definition like we have here, acute tubular necrosis like our tubule come necrose and the kidney function damaged. So the kidney failure and fail to excrete the blood, exit the waste from the blood. And in acute glomerulonephritis, inflammation can reduce renal blood flow and cause ARF. Okay, next. Ischemic acute tubular nephrosis. Severe and irreversible damage to the kidney tubule with patchy cellular necrosis and sloughing. First, the tubular cells did not have enough oxygen from the volume depletion of blood. The decrease of blood volume go through the kidney, make the tubular cells do not get enough oxygen, and then severe irreversible damage to the kidney tubule with patchy cellular necrosis. Patchy, some of tubule that necrosis and sloughing will reduce the glomerular filtration rate. Okay, next, acute tubular necrosis will become toxic. The tubular cells are exposed to a toxic substance like antibiotic. Proximal tubular epithelial necrosis and sloughing. The tubule become more permeable, increase filtrate reabsorption. When the tubule become more permeable, the reabsorption rate will increase and the filtration abnormal, then reducing the ability of the nephrons to eliminate waste. Okay, next. Okay, risk factor of acute tubular necrosis will come from some major surgery and severe hypovolemic, patient that will undergo sepsis, trauma, or burns. Okay, cause and clinical manifestation of ARF due to acute tubular necrosis. For the intrinsic factors include three phases. Initiation phase, or we call starting phase. Next, second phase is maintenance, and third is recovery phase. For starting phase or initiation phase, the phase will last for hours to days. Begin with hemorrhage, some kind of hemorrhage, and when tubular injury occurs, prognosis is good if we can recognize the signs and symptoms early and treated effectively. Okay, for maintenance phase, characterized by a significant fall in GFR and tubular necrosis, oligorrhea may develop. If urine may be produced, the kidney cannot efficiently eliminate metabolic waste, water acids, and electrolytes. Okay, next. Okay, for maintenance phase, patient will develop exothermia, fluid retentions, electrolyte imbalance, and metabolic acidosis. Some impact potassium excretion leads to hypokalemia, effects to neuromuscular function, as example, ECG changes, and possible cardiac arrest, muscle weakness, nausea, diarrhea, and salt water retention that can cause patient having edema. Okay, cause and clinical manifestation of acute renal failure due to acute tubular nephrosis for recovery phase was characterized by a process of tubule cell repair. The tubule cell was repaired in this phase and regenerate, gradual return of the from the decrease of GFR to normal or pre-AKI levels. Okay, diuresis will occur here. Like before, the diuresis can be occur. For the recovery phase, diuresis occur like normally, and then so nephrons and our GFR recover like normal, and retain salt, water, and solute also excreted like the kidney functions normally. For serum creatinine, blood urine nitrogen, potassium, and phosphate level remain same. And at this phase, renal function improve rapidly. First 5 to 35 days of the recovery phase, then continue up to 1 year for the recovery phase. Not so urgent recovery for the recovery phase. Not for fast recovery. Okay. Pathophysiology for post-renal, urine will be obstructed flow by intrinsic or extrinsic means, increase in tubular pressure, which decrease our GFR, and increased pressure within the renal collecting system result in a fall in the GFR, reduced tubular reabsorption of sodium and water, acquired tubular acidosis, and phosphaturia. Okay. Here we can see the causes of acute renal failure. First, pre-renal, intrarenal, post-renal. Pre-renal come from our blood vessels, which is sudden drop in blood pressure that having our kidney less blood volume go to filter in the kidney. And then intrarenal, direct damage to the kidneys by inflammation toxin drugs. Intrarenal, mostly the causes come from the kidney itself. And then post-renal, sudden obstruction of urine flow due to enlarged prostate, example enlarged prostate, or what we call that, kidney stone, some problem is the bladder, and that can have a sudden obstruction of urine flow. Okay, here we go to interdisciplinary care. We have diagnosis, medications, nutrition and fluid management, and renal replacement therapy. Okay, interdisciplinary care. We have here for patient assessment for diagnosis. Patient assessment, we should have the past and current lab test for the patient, like RP, blood investigation commonly, RP, FBC, serum creatinine, vital sign. We should have for baseline patient, if patient having hypertension, to know patient have a normal blood pressure or high blood pressure that can damage the kidney. And then intake and output chart for the maintenance of the intake and output. Daily weight, if patient have some edema and we want to know the excretion of water retention from their body. And fluid and medication review throughout history and physical examination. Okay, for diagnostic test, blood test that I talked before, ABG, FBCRP, serum creatinine, and urine analysis. Okay, for medication, acute kidney injury. First, dopamine. Dopamine, the drugs that can function centrally and peripherally, means the dopamine will function for our body, and for the kidney itself. And then loop and osmotic diuretic, as example, furosemide, to excrete the waste product in our body, or excrete the what we call that fluid overload in our body. And ACE inhibitor, as example, perindopril, to control the blood pressure. H2 receptor antagonist, cimetidine, and some of patients will have cocktail to manage the ECG rhythm. So from the drug, we take note that not all the patients will have antibiotic, what we call that, antibiotic that suitable for them. Some antibiotic can have nephrotoxic to their kidney. Okay, next. Okay, for nutrition therapy for patient with AKI, we should restrict dietary protein. Serve patient with low salt diet protein. Serve patient with high calorie intake to maintain adequate calorie intake. Sodium, potassium, and phosphorus should be restricted. Okay, for fluid management, maintain fluid intake for patient 1 to 1.2 liter per daily. And next, for interdisciplinary care, RRT dialysis. In RRT, renal replacement therapy dialysis, we have here hemodialysis. Hemodialysis, we divide by 4, CRRT, CABH, CABHD, and CVBHD. And then peritoneal dialysis, because some of patients don't want to have hemodialysis, they choose to have peritoneal dialysis. And vascular access. Vascular access, like patient will undergoing some of AV graft insertion or AV fistula, or insertion of catheter to go through the hemodialysis. Okay, next. Okay, dialysis. Dialysis is method to remove fluid and uremic waste product from the body when the kidneys are unable to do so. The hemodialysis take part of the function of the kidney. And the methods of therapy include hemodialysis, CRRT, and peritoneal dialysis. This is one of example of catheter or permanent catheter that inserted in patient veins. Okay, hemodialysis, most common method of dialysis, done 3 times a week, and then determined by body size, residual renal function, and dietary intake. Objective of the hemodialysis is to extract the toxic contained in our body, and then remove excess water. The blood with toxin and nitrogenous waste is diverted from the patient to a machine. All the waste thing diverted to the machine, and a dialyzer where toxin are removed and the blood is returned to the patient. All the blood, cleansed blood is returned to the patient back for the using in body. Hemodialysis, principle of HD. We have 3 principles here: diffusion, osmosis, and ultrafiltration. All the toxin waste product removed from diffusion. water removed from the osmosis, and cleans blood return to the body through what we call it, cleanse blood is returned to the body at the end of dialysis treatment. Many waste products have been removed. The electrolyte balance has been restored to normal. Okay, now we go to CRRT. CRRT indicated for patient with acute renal failure that are unstable for hemodialysis and fluid overload with secondary to oliguria. Patient that have maintained oliguria and not suitable for hemodialysis, we can go through CRRT. Okay, CRRT method similar that they require access to the circulation and blood pass through an artificial filter. Okay, we have two CRRT method. First, CABH and CABHD. CABHD are no longer used, but we always use CABH, continuous arterial venous hemofiltration. Okay, next. Okay, there was two blood hemodialysis here, CBBH and CBBHD, but usually we go to patient go to CABH lah. Okay, continuous venous hemofiltration CBBH used to manage acute renal failure. Double lumen inserted to the patient through hemofilter and then returned to the patient through the same catheter. CBBH provide continuous slow fluid removal ultrafiltration, or we call the ultrafiltration. CABH. Okay, CBBHD, like similar to CBBH also. Blood pumped from a double lumen venous catheter to a hemofilter and returned to the patient through the same catheter. Uses a concentration gradient to facilitate the removal of uric toxics and fluid. Okay, peritoneal dialysis. Some of you know what is peritoneal dialysis, right? Okay, peritoneal dialysis remove toxic substances and metabolic waste and to establish nerve fluid and electrolyte imbalance. In PD, the peritoneal membrane that covers the abdominal organs and lines the abdominal walls, semi-permeable membrane. Sterile water is instilled into peritoneal cavity through a catheter. Patient will have some incision in the abdomen, go through the peritoneum, and the sterile water will take part there. Peritoneal dialysis. Okay, here we show about metabolic waste products and excess electrolytes diffused in the dialysate will remain in the abdomen. Water movement is controlled using the dextrose. Dextrose act as osmotic agents, and the fluid drained by gravity out of peritoneal cavity into a sterile bag. The process repeatedly at prescribed intervals. Excess fluids and solids are removed gradually, less risk for unstable client. It usually takes 36 to 48 hours to achieve what HD accomplished in 4 hours. PD, normally patient stable, we have PD, and unstable, we have CBBHD or hemodialysis. Okay, complication of peritoneal dialysis. Peritonitis, common and serious complication of peritoneal dialysis, characterized by cloudy dialysis drainage, diffuse abdominal pain and rebound tenderness. Leakage of dialysate through the catheter site occur immediately after the catheter inserted. Avoided by using a small amount of dialysate, gradually increase the volume. Okay, next. Okay, complication of PD. Bleeding is one of complication of PD. Blood drainage may be observed occasionally. Bleeding is common during the first few exchanges after a catheter insertion because some blood enter abdominal cavity following insertion. Okay, next. Okay. Last but not least, our nursing diagnosis here. I plot 6. 1, 2, 3, 4, 5, 6. Okay, 6 nursing care plans here and nursing diagnosis. First, patient will have excess fluid volume, risk for decreased cardiac output, risk for imbalanced nutrition less than body requirement, risk for infection, risk for deficient fluid volume and deficient knowledge. But in our slide, I have for excess fluid volume only. Okay, excess fluid volume, increased isotonic fluid retention related to renal failure. Okay, our desired outcomes, we will have display of appropriate urinary output with specific gravity or laboratory studies near normal, stable weight of patient, vital signs with the patient's normal range, and absence of edema for patient. Okay, here all the nursing interventions and rationale. First, nursing intervention accurately record intake and output chart, monitor urine specific gravity, wake patient daily at the same time of the day, assess skin, face, and independent areas for edema, monitor heart rate, BP, for if patient has hypertension, and then auscultate lung and heart sounds. Assess level of consciousness because patient will have drowsy, investigate changes in mentation, presence of restlessness, and then scatter desired beverages throughout the 24 hours period, and then correct any reversible cause of ARF. If patient have anemia, patient doctor will ask us to transfuse blood for the patient to maintain the blood loss, to maintain the blood volume in the body, and then discontinue nephrotoxic drug and relief obstruction via surgery if patient have obstruction in the kidney. And next, use appropriate safety measures, raising side rails and restraint, because patient will have a CNS involvement, the patient confused because of exothermia. And next, okay, that's all for today. Thank you for your attention. Any questions?
Miss, I have one question.
Okay.
How volume depletion can cause acute kidney injury?
Okay, volume depletion cause kidney injury by some kind of incident like massive blood loss, that make the kidney loss of function because of less blood volume go to the kidney to function like always.
Okay, thank you.
Okay, Miss, I have one more question. Kidney is the great worker, alhamdulillah, in our body. Okay, in my radiology department, have many patients going for like a CT with contrast, like CT abdomen with contrast. So my question is, how contrast agent can affect our kidney?
Okay, as we talked before, the patient that are undergoing the CT scan or some kind of radiologic procedure that involve the contrast, the contrast is more concentrated than our blood. So when the contrast go through the kidney, because we inject directly to the vein, and the contrast will go through our kidney, the concentrated will affected the kidney to function like usual. So for patient that have problem in kidney, will getting the kidney function worse than before.
Thank you.
Yes, if that's all for today. Thank you for your attention and involvement for my presentation, and see you next class. Thank you.
Thank you.
Thank you.